sequel of any blockbuster is not as good. And I feel exactly after the talk of Florim and Alok that I am a sequel. But let me do my best. Good evening, ladies and gentlemen. When do I not use the stent? There are multiple situations when I wouldn't want to use the stent. For example, ambiguous landing zones, thrombus obscuring the lesions, either distally on the landing zones or the proximally. TIMI3 flow is achieved in the infarct-related artery after thrombectomy, and there is no clear lesion seen. A young individual, even without a risk, and purely a thrombotic lesion. Side branch of a main vessel which is provisionally stented. Unfavorable angle of the side branch for two-stent strategy in a bifurcation. Distal LAD lesion for any risk individuals. Now, this is an area which you would definitely want to leave for grafting in case the individual is very young and has a very, very high risk of recurrence. Small vessels, long lesions, difficult to track the stent into the lesion, and a desperate situation. I remember once we had a LAD lesion, patient presented with LAD syndrome, and no matter what angle we took, we just could not delineate the proximal end of the lesion very well. So there are such situations, and why do I not want to stent in these situations? Because the risk of stenosis, aneurysm formation, stent thrombosis, loss of vasomotion, which is very sufficiently talked about, accelerated atherosclerosis in other vessels, delayed TLR and TVFs, which is commoner, need for long-term antiplatelets, and the risk of bleeding, which is actually a very dynamic phenomenon, which means today you are not a high bleeding risk, but tomorrow you could be. Case number 1, where there is more thrombus due to polycythemia vera, a known patient presented with a hemoglobin of 22 and anterior wall myocardial ischemia and STEMI, and there is no reason why, if there is no underlying critical atherosclerotic lesion and purely a thrombotic lesion, we should be putting in a stent. A second case where you have a Jeopardy of a major side branch, like a trifurcating left main, a major ramus coming out, and a critical proximal circumflex lesion. There is a good landing zone for the circumflex, so you can probably put in a stent there. And I think I want to reiterate once again what Florim said, that all of us know stenting extremely well. What we need to know is the angioplasty. I think in this situation, if I had to put in a stent at the ostium of the ramus, I would probably land up flowing a lot of adrenaline and would probably compromise the LAD ostium or the circumflex ostium. In a situation like this, I decided to do the angiosculpt dilatation of the ramus origin and do the DCB dilatation, and the follow-up angiogram a few months later showed that the lesions were still holding very well and there was good flow. Thrombosuction done in a patient with extensive anterior wall infarction leaves a clear vessel. There is no underlying lesion, but my fellow decided to apply the DCB, and the result is still holding pretty well after 3 years. This is ISR, fourth case due to neointimal hyperplasia, twice angioplasty on the LAD, now inducible ischemia with some symptoms in the LAD territory on myocardial perfusion, and CAG revealed that there was a moderate instant restenosis. There was melon seeding while balloon dilatation, so we decided to do the angiosculpt post DCB. This was the result and is holding well. If you have an important side branch and a proximal lesion, you can probably do the side branch dilatation with a drug-coated balloon and put in a proximal stent. Very young fellow presenting with cardiogenic shock, multiple episodes of VF requiring DC cardioversion, requiring a prolonged CPR. When you do the angio, you find a totally occluded left main. You are successfully able to wire the LAD, wire the circumflex, do multiple balloon dilatations, multiple thrombosuctions, but despite that, this is what you achieve. But you have almost TIMI3 flow in both the vessels, patient is stabilized, so it's decided that we leave the patient alone on GP2B3 receptors, antagonists, low molecular weight heparin, and DAPT. And pre-discharge angio shows that there is a significant clearance of thrombus from the circumflex, but some residual thrombus in the LAD, which was dealt with by giving oral anticoagulants for a period of 6 weeks. And 6 weeks later, there is a total clearance of thrombus from LAD as well. Stenting is avoided, and so is long-term need for DAPT. Small vessel distal side branch disease. You can see that the proximal lesion was stented and the distal was balloon dilated. Though you see that there is some degree of pinching, or you see some plaque shift into the PDA, this gentleman has had CT coronary angiogram 2 months back, and that vessel is flowing extremely well. So unjailing of the side branch over a period of time with the use of drug-coated balloon dilatations is known. Diffuse distal LAD disease, which is one of the commonest indications in my practice, not to use a stent, to leave that area free of metal. You can see a bubblogram there, a nice bubblogram. The distal LAD was dilated with the drug-coated balloon. In a situation like this where you have one focal lesion, a stent can be used and the distal LAD can be balloon dilated. This is once again a similar situation where the distal LAD was dilated with a drug-coated balloon, and long-term patency is still very well preserved. One more situation, a very young fellow presenting with a bifurcational lesion in the circumflex OM and distal LAD disease. The circumflex and OM disease was dealt with a bifurcational strategy, and distal LAD was balloon dilated with a drug-coated balloon. This is another interesting case where a 30-year-old presented with acute coronary syndrome, a bifurcational circ OM, a bifurcational LAD diagonal, and you can see that the RCA is also filling retrogradely. Only 30 years, homozygous hypercholesterolemia, distal LAD, drug-coated balloon dilatation because of the possibility of recurrence of problem in this particular young individual with a very high risk. Bifurcation of the LAD diagonal was dealt with 2 stents, and the RCA was totally occluded with an aneurysm, which was also successfully dealt. He has had myocardial perfusion scan 6 months back, which is normal. This is very interesting. This gentleman was a marathoner, presented after a long run with a history of syncope, was taken to the hospital with lots of ECG changes, you can see that this was done in 2014, had a proximal critical disease in the LAD and diffuse disease in the LAD. The proximal disease of the LAD was stented, and the distal disease was treated with drug-coated balloon. 6 months later, the stent is holding on well. The distal LAD disease is also holding fairly well. And now, 8 years later, that is in 2022, the stent is holding well. The distal LAD is also holding extremely well. He has had a coronary angiogram recently, and which is once again showing good results. Almost 10-year follow-up. The take-home messages are: intact endothelium-dependent vasomotion is an important prerequisite of vascular health. Vasomotion is also an important mechanism for controlling microvascular perfusion. Vasomotion refers to rhythmic oscillations in arteriolar diameters over the period of time. Vasomotion contributes to autoregulation. Nitric oxide released from intact endothelium is a trophic substance, and there is a nitric oxide mediated endothelium-dependent vasodilatation, which is very important, which may be lost post-stenting. All these mechanisms help to ward off the pathogenic mechanisms involved in atherogenesis. So all the therapies like DCB and BVS, which will treat critical and ischemia-producing stenosis, yet will keep vasomotion intact, will definitely find a permanent place in future therapies. These are the conclusions. Use DCB because it normalizes the shear stress, restores normal vessel curvature, reduced risk of late polymer reaction. Avoid delayed acquired malapposition because the late luminal loss is more often seen with DES than with DCB. And that is also one of the reasons for very late stent thrombosis due to acquired malapposition. Avoids late strut fractures, reduces neoatherosclerosis, unjailing of the side branches. Late bypass surgery options are open, allows treatment of ISR without necessitating the permanent additional metal layer, facilitates non-invasive imaging follow-up without artifacts, and keeps the vasomotion intact. But we need more evidence in favor of this. Thank you.